we are going to spend just a couple of minutes kind of doing some background stuff here. And we're going to take a look at the results of the survey that we did. Then we've got 3 challenge questions. That was part of the survey. There were challenge questions. We asked if anyone had challenge questions, and 3 of them were particularly, we thought, interesting. And so we've asked each of those individuals, you know who you are, to help facilitate a discussion about these and see if we can sort of dig deeper. And then by the time we get through that, we'll probably be pretty much finished with our meeting. Let me just quickly mention the objectives. We went through these last time. We want to prioritize critical issues. You're helping us to prioritize critical issues in healthcare. You're helping us to better advise our customers. We do validate what we're giving to our clients in terms of advice. We validate it based on the things that you tell us in these meetings, as well as other sources that we have, but we rely on you pretty heavily. You also help us focus on what's ideally going to be most important, what's coming, what should we be focused on investing in. I will mention very briefly that coming out of the last meeting, we did use the material that you provided for us last time. We've used a couple of pieces of it. We produced a podcast using the technology component that segment that we talked about. That's been listened to. We did Neil and Sarah and I did a deeper dive into that. We added some additional research to it, and a lot of people have listened to that. We've put out some additional, put out a press release. We put out some additional information based on the findings. We've used the findings to inform at least one of the major projects that I've been working on with Novartis in the area of variation and patient safety. And then we also plan to do another podcast deep dive into managing the poorly insured that we had a discussion on previously as well. So we've been using the information that you have provided to us. Some of the ground rules, we talked about these last time. Please engage. This is an opportunity for us to ask questions, to talk, to challenge. Ideally, we'll keep it G-rated, showing respect for one another, listening, trying to learn, trying to be open-minded. We're hoping that all of us will get something out of these kinds of discussions. And to the best of our ability, we'll start and end on time, but you're free at the end of the 90 minutes to hang up if you want to. Couple of the logistics. We're telling everyone that we are recording this. We are recording it for note-taking purposes. We are not publishing this recording. This is internal only. We're not using any of the video. This is a video recorded program. We're not using the video component of it. If for any reason we decided we would like to, we would ask for your permission for that before we would use it. We do, however, reference anonymously your comments. We've not used anyone's name specifically when we've referenced things that people have said from this group. If we wanted to use your name in something, we would ask you for that. And just like last time, to process the honoraria, we would need to make sure we have a current W-9 from everyone. I think we've got that now from everybody, so I think we're good on that. Wanted to mention briefly that we do have other networks going on, so it gives you kind of a perspective of really what we're trying to do. We have 8 different networking or business work groups that are currently working on different initiatives. We have a population health leaders network. We have a women's health research collaborative. There's a specific group dealing with NASH, which is a liver disease called NASHNet. We're actually a facilitator for that one. And it's an independent group. Of course, we have the Hospital System Executive Advisory Board. The Oncology Leaders Advisory Board is getting started right now. That Neil and I and Sarah are leading that one as well. We have another working group on CKD, one on behavioral health, and one on senior healthy aging. The idea is to integrate these, be able to overlap, to use the learnings across these different things, especially the Population Health Leaders Network, looking at things that look across health systems, hospitals, and different disease groups. This particular slide I wanted to show because it shows you what TKG is trying to achieve through these groups. And I've actually woven this into our discussions later. You'll see in the slide deck that we've got this built in. We're creating multi-stakeholder groups to generate insights, sharing those insights among each other within this particular this panel, looking to identify, define, disseminate best practices. Where we have opportunities, we'd like then to validate those best practices or those ideas. Try to build real world evidence. We actually have an opportunity right now that Sarah, JP, and I are working on with the American Cancer Society to do a real world evidence based project around patient navigation in low middle income countries. So that's a good opportunity to leverage some of the work being done in some of these work groups, and then ideally activate those learnings. We validate them. We try to activate them to actually get them into use, find ways to scale them and get them into use, connect them with purpose. So kind of a 4-step process. As we're thinking about our work, as we work together, we are trying to think about how do we define those best practices, how do we validate them, and then how do we actually put them to work. Thoughts, questions, or anything from the rest of the group or from the TKG team? Okay. Well, let me turn it over to Sarah. And Sarah, if you could kind of walk us through, is this where we wanted to be? Or do you tell me where we want to be?
Next slide.
Okay.
There we go. All right, so thank you everyone for taking time to participate in our survey that we sent out a few weeks ago. We really wanted to understand what this new normal is beginning to look like and how really the COVID pandemic has shaped how healthcare is being delivered. Has it changed our challenges? What innovations has it spurred? And when we looked at all of the answers to the questions that we sent, we really saw some key themes that were pulled throughout. And these probably aren't surprising to anyone here on the panel. Financial and reimbursement, looking at administrative. We all know about, remote operations, employee engagement, things like that. And then obviously the patient, what this has done for the patient in terms of financial needs and how to re-engage after the pandemic or as the pandemic is hopefully dying down. So we looked at really 3 categories, one being adaptation and innovation, and we had a lot of good feedback on innovative delivery systems that you guys shared, and we're going to talk about some of these today. But there was a lot of discussion in the surveys about more intense services provided in the home and those hospital at home type services, infusions away from the hospitals, things like that. Obviously, virtual video visits and, figuring out how we can do as much care delivery as we can in a safe manner, whether that be curbside care delivery or using those virtual visits. And then also with the pandemic, we all know that there's become a big focus on mental health services and how do we deliver that care, when we can't see patients as much, but they need us even more, arguably, with everything going on with the pandemic. So we're going to talk a little bit more about those as the discussions move along today. We asked you about what the new normal was going to look like in terms of, what you've seen, what you're predicting. And we did get some predictions on, percentages of how many of these visits that are virtual visits are going to stay virtual versus move back to face-to-face visits within the clinics. There's also the concept of new competition coming along. So now that almost everybody is delivering telehealth, how do you get ahead of the curve, and how do you set yourself apart when it comes to delivering these services, especially in more competitive areas in the market? And then, of course, coding, office space. Where are people working? Are they coming back in? What are we doing with this excess office space? Those are all questions that we're going to be working through as the year progresses. And then finally, we have our continued challenges, and these are not unlike what we've experienced before, but really understanding, reimbursement, whether that's reimbursement for the services provided. We had some discussion about compensation plans for physicians and making sure that they're aligned with organizational goals. There was also the concept of employee fatigue and burnout, and all of these Zoom meetings and Microsoft Teams meetings. How are they impacting our employee satisfaction, and how is that then correlated with the care that we're being delivered, and how do we kind of pull some of that back in and maintain those teams that we had when your staff members may continue to stay remote for a period of time, if not indefinitely. And then how do we get the patients back in? Some have really enjoyed telehealth visits, and, they're going to not want to maybe come in and potentially be exposed in the coming year. The relationships that have possibly diminished a little bit between patients and providers, we really need to understand how we're going to re-engage our patients across the continuum as we wind down, hopefully, this pandemic. So that's just kind of a real quick overview of some of the things we heard from all of you guys. We're going to do a deep dive into 3 of the topics. And then at the end, if there's something that you shared that you think is really important to discuss today and really important for us at TKG to know about, we're going to have a little bit of time at the end to discuss, to kind of come back to these ideas and discuss any extraneous ideas that we haven't had a deep dive in. Warren?
Great. Thank you, Sarah. So the way we've structured this is, as I mentioned previously, from that survey, from that information and feedback that you gave us, we picked 3 these challenges that you said, here are challenges that we think we're facing or we'd like to have a discussion around. And the first one, David McGuire has offered to facilitate the discussion. This would be challenges in achieving value-based reimbursement. Then we'll jump to Tim Atterbury talking about physician compensation and incentive alignment. And then Mike Blair will lead us in discussing patient utilization and getting patients to re-engage. As we do this, I'm going to jump now to this. We're only going to have one slide here for a moment, and then I'm going to put up the whiteboard and let Andrea help to actually capture your thoughts and ideas. But at the bottom of this, each of these next 3 discussions, you'll see that the goal is to generate insights, define best practices if there are best practices, validate through real world evidence, and then activate with purpose. So if there are things that you can ideally turn us loose with as the TKG team and say, here, please do this for us to help us, or this is what needs to be done next, we would love to be able to walk away from this meeting, perhaps with a little bit of follow-up through a follow-up survey, with a to-do list, a task list for the TKG team to follow up on and on some initiatives to actually implement and activate what we're talking about here. So,
well, Warren, just a quick comment. First I want to, of course, as you would as well, thank the 3 facilitators who volunteered to do this. Also want to mention, though, that there are several others who volunteered to facilitate a topic, and we really appreciate you offering that as well. We had time for 3, and we had to prioritize based upon sort of consensus of the group and the needs of TKG, but we hope that won't inhibit you from offering to do something similarly in the future, because we really value all your participation.
Thank you, Neil. And as we go through this, please make this a working discussion. So the kinds of things that we'll be talking about, you won't see these questions when we put up the whiteboard, because I can't figure out how to have both up at the same time. But things like, what are the barriers to achieving value-based reimbursement? What do health systems need to be effective at value? What do they need to be effective at value-based reimbursement? Are there successful models now or elements of models that could be used to guide future models? And what can we do to innovate and contribute to future models? So David, I'm going to ask you to unmute, and we'll turn it over to David McGuire. And at the same time, I am going to stop this screen share and go to a new screen share. And hopefully Andrea can see if Andrea is able to, or maybe Andrea, you would need to share from your screen.
I think that's the case, Warren. It won't let me capture the writing tools when you share. So I will do that.
Okay, are you ready?
Go ahead, David.
So again, I'm David McGuire from Mass General Brigham in Boston. So I'm particularly interested in the challenges of value-based payment, especially as a business model. It's one thing as a sort of an add-on, nice thing to do for the world, but as in terms of making it a reimbursement model that drives investment and strategy, that is really hard to get to. So I'm going to introduce that, and at the end, you saw some questions. I'm interested in what have people tried, what are the lessons you've learned, and what do you think are the best directions from here? So, Mass General Brigham signed its first risk agreement in 1996, the year I got there. Dropped out of risk in 2003 and went back into budget-based risk in 2012, largely in the aftermath of Massachusetts health reform. So a lot of pressure by the state and by regulators once access had been achieved to focus on cost containment so that it would all be affordable. In the second round of risk, we took on budget-based or trend-based risk models or target models. And I think those types of things have been used for the Medicare ACO models based on some element of a market trend. The good thing about that sort of model is that it starts from a baseline of the real world. What are your prices? What have your spending level been? Your patterns of care, and the risk profile of your patients. So you're not trying to come up with technical adjustments or sort of a revolution in the state of what is, but provide incentives to do better. And so in that sense, it works very well. You're incentivized to improve trend since there's so much that's unpredictable, like new drugs and new high-cost diagnostic methods and so forth. You often use some version of a market-based trend in order to account for those types of changes. What affects everybody else is likely affecting you and vice versa. So the difficulty with that kind of model as a business driver is if you're working in a market where everyone is activated to do likewise, the trend targets are difficult to achieve year after year, and most of the savings goes back to the government or to the payer. So as a business model, it's a tough one to be excited about. You usually take partial risk. And so if you're doing expensive revenue reducing initiatives in order to do well, you only retain a portion of that, even on the business that you're at risk for. And as we know, the baseline resets. The government resets the baseline after a few years. Lots of times commercial arrangements do the same thing. You still have to pay for the costs of the program that caused those initial improvements but you're not getting savings from those. You've got to invest in new things to generate new savings. That's not a great business model. And I don't think very many of these initiatives ever break even, meaning that they pay for the infrastructure that creates the improvement and then also generates a margin. You know, alternatives are things like bundles, percent of premium, premium trend, or capitation, and those sorts of things. So that's been our experience. Our strategy is still largely driven by where can we find fee-for-service commercial business. We do the other, it's important. We try to grow lives, but the money that comes from fee-for-service. So again, coming back to those questions, you know, what has your experience been? What lessons have you learned? What do you think are fruitful models for the future would be great? I guess the last thing I'd just like to point out is that, you know, Armika is on the phone from Kaiser, and I have always been envious that Kaiser, the future has come back to the Kaiser model. They don't have these barriers, at least to my knowledge. Their money comes in at the beginning of the month, and so they can focus on how do we deliver the best value for that money that's already here. That's value-based competition and value-based reimbursement. So with that, I'll let it go.
Do you want us to just jump in with kind of thoughts and experience, Warren? And
yes,
yeah.
Let's.
Okay.
And obviously we have a challenge for Armika, so Armika be thinking.
Yeah, I'm happy to jump in with our experience because it's a really timely topic. We signed our first value-based contract in 2014, and we of course did upside only until 2016. We have contracts across commercial, Medicare, Medicaid. We have a lot of managed care in those. So we have contracts with our current commercial payers, and there's only two sizable ones in our market. And we have contracts across each of those lines of business. So commercial, Medicare, Medicaid for two of the large payers, and then a few employer-based contracts. And like you said, most of them are based on trend, either trend in total spend or trend in percent of premium, spent on medical services for the governmental payers, where the plans are on a budget as well. I think one of the things that we identified early on is important to, and we were able with our first two payers, as well as the employers, to negotiate for care management or infrastructure, PMPM type payments up front. They aren't huge, but at least, it's something to help build the care management infrastructure that you need. And in fact, there's a large Medicaid payer in our state that we have refused a contract with yet, even though they want for us to do a value-based contract with them, because they won't provide that upfront, what we call infrastructure or care management fee. Our gains, since we've been doing this, have been relatively small relative to fee for service. So we've had about a little over 65 million in gain sharing over the 4 or 5 years. So that's not a lot compared to your fee for service business, as you mentioned. But one of the things we've learned is by having these contracts, we have access to all the payer data. And so our ability to assess leakage was much better than it was prior when we didn't have the data. So we were able to build models with our providers where we could actually share with them what leakage was. And we only did contracts, I should say, around our primary care network. So a first step was building a big, large primary care network. So the only lives under contract were our primary care lives. So getting the data on where these patients were referred was really important to us. And so we were able to use those data to really grow our fee for service business. right? Because we tapped into any of our patients that were referred outside our network for service. We kind of worked with those, but we had visibility to that. We worked with those providers to bring that business back in. So that was kind of one of, how we balance. We found advantages on the fee-for-service side, which was really important, as well as, gain share. And of course, fiscal 20 was a banner year, right? If you were in gain sharing contracts, because, spend was so low that we beat budget, pretty significantly. And we were able to negotiate taking fiscal year 20 out of our trend going forward. So we are not using fiscal year 20 and that trend in future years. So I'll stop there. I'm sure others have experience.
Sarah, I just wanted to point out that wasn't Armika speaking. That was Kathy. That's not the Kaiser experience. Yeah.
Yeah. I'm sorry.
Yep.
Yes, I thought you knew that. You were giving Armika a chance to think on that, right?
Yes, correct.
Yeah. So this is the Rochester experience. That's right.
Hey, Kathy, quick question. This sort of it will be later a segue to the next topic that Tim Atterbury is facilitating. But you mentioned primary care. Now, I'm just curious.
Don't worry about it, Andrew.
Are those primary care physicians employed by your organization, or do you have some sort of contractual relationship with them?
Yeah, thanks for asking the question. So this network that we developed includes all of our employed physicians. And frankly, we have about a couple hundred employed primary care docs, but we also allowed physicians in the community to basically join our network. They paid a nominal fee to join. The commitment is they can only be in our value-based contracts. They can't be in others. And they have to comply with the submission of data, the e-records, certain protocols that get developed. We can eliminate them from our network if they fail to comply with those things. So it's a combination of employed primary care and community-based primary care. And actually the same thing with specialists. We're a huge employer-based model, obviously. So the lion's share of physicians are employed, but there's a fair amount of both primary care and specialists that are community-based and joined our network for purposes of participating in these value-based contracts. And they get direct, the private groups get, we pay gain sharing back based on a formula directly to physicians.
So Kathy, you're describing that experience of this provides an incentive to get going, to get physicians motivated and working together on population health initiatives.
Exactly.
And you got to start, and these are great vehicles to do that.
Yeah, exactly. But again, as you noted, David, the gain sharing that you get each year, a low side, maybe a $5 million or $10 million, high side, we had a 20 million year, pale in comparison with, the fee for service, the margins on fee for service. But like I said, by bringing this network together and having really insight into where referrals were going, we were able to capture a lot more business within this big network. So fee for service revenue actually went up due to volume.
Yep.
Kathy, that's a great point that people don't often think about, that sometimes participation in various value-based care models bring you more than just the shared savings or just the financial component. I know with oncology care model, as we participated in that UAB, with the results were marginal and the baseline kept going up. So you really, the gain sharing was small, even though it was positive, but we learned so much, and having the data was so valuable that there were other aspects of it that really helped us to organize in a better, more efficient way. So we got more out of it than just the financial piece.
Right. I think the other thing, last thing I'll say is, to do this successfully, you have to build your care management infrastructure. And so we did that. I had to do that. I did that, which was helpful in these patients that were under contract. But the care management strategies were also helpful in our patients that weren't under contract. We're a huge regional referral source. So we get a lot of patients referred in who aren't under any value-based contract, but, the positions and the work we put into place helped us manage those patients better. If you follow me. So that was kind of an important spin-off as well, is you had to develop expertise in care management to be successful, but then that expertise is able to be used on other populations.
I'll bet Ochsner and Kaiser have done, I know Ochsner's done things network-wise that may fit in here, and Kaiser, we've asked for some feedback there as well. Thoughts from either of the two of you?
Sure, I'll go first, and we'll let her finish off with filling in all the gaps. I think one of the first components is attribution. So kind of knowing who's in play and who's out of play is really important. If you're going to be trying to pull some of these levers and fine tune it, knowing exactly what will count against you and having that defined by all parties involved early really smooths things out. The other thing that's already been mentioned is these narrow margins. I feel there's also value in working with all the stakeholders to say, what are we doing to improve the likelihood of a successful outcome? So are you providing, refill support? Are you providing clinical decision support? Where do we have duplications of effort so that we are not wasting labor? And where do we have gaps in our care that we can actually get bang for our buck? And so assessing, okay, how is attribution determined? What are our covered lives that we're talking about? What are we using as our scorecard? What do we define as success? Whether it's per member per month, whether it's quality gates, everybody knows the rules so that at the end of the game, when you're trying to chop the pot, everybody feels like they got a fair shake. And then, once everybody agrees to the rules, it's a lot easier to try to pull in the same direction, because you're also attempting to overcome some of these, disincentives by some members of the collaboration. One of the other favorite Ochsner sayings is, as fee for service goes down, value for service goes up. And so using the value-based contracting to offset compressed margins and fee for service, hypothetically, is a play here. And I think in 2020 with COVID and decreased utilization, I think we've seen some of that in certain health systems that had a larger impact than others. But I think that would be a bellwether for how extensively leveraged are you in value-based care. And that would be reflected in when all of the fee-for-service dried up in March, April, May, how did it look within your organization? That would be an indicator for how much value-based contracting and what impact does it have on our general bottom line. I would also state probably the harder one is, how do you move the lever? So obviously with the Medicares, you have star measures. There's a lot of opportunity there. ACOs, you can get a little bit more creative with the ACO safe harbors, depending on what your legal department thinks. But pulling these levers to try to move your quality gap and to try to both improve the health of the patient, decrease waste and utilization, while providing better care, that's where the magic is. And then pulling together your clinical teams, your operational teams, your IS teams, and then once you decide on the rules of the game, actually trying to move the dial. And I think that's where that'll make or break most of the organizations jumping into value-based contracting. And then being able to, at the end of the day, prove that with data.
So I have a couple of questions for the group. That was great. Thank you all this far. One, I guess this kind of relate to thinking about if I were a life sciences company client of TKG, what would I be thinking about? One thing I'm thinking about is, how do I sell specialty products for specialty-based issues. And so one question comes to mind is, how effective are risk adjustments in this whole game? So for example, the theory is that if you provide better care and if it's more expensive, long-term costs will be lower. But oftentimes you don't have that patient over the 5 or 10-year period that is necessary to really be able to measure that cost reduction. So hence there's this idea of risk adjustment. And what's been your experience with that? Does it work? Does it help?
I think it depends on your partners. Go ahead, David.
No, Matthew, go ahead.
All right. I think it depends on your partners and how it's being pitched. One thing that I have noticed is also when you are working with the Medicare and the ACOs and your different value-based collaborations, if somebody is covering, if it's a PBM relationship, they're going to focus more on your Part D retail side. If it's more of a Medvantage product, it's a little bit more all-inclusive. But for some components, if you're only looking at the Part D, I'm finding they usually try to push some of the costs into the B side. Whereas if you're self-funded, you're eating all of that cost anyway. And so there was recent data that showed some anti-diabetic agents had benefit for heart failure, but they're generally also expensive. From a big picture standpoint, those agents hypothetically should decrease morbidity and mortality, decrease utilization and inpatient stays. In the big picture, save money for the organization on a value-based program. However, in the short run, you're going to see an increase in PMPM on your retail pharmacy side. And that's generally part of the specialty component. So if it was somebody looking to cut costs in your specialty pharmacy division, they're going to tell you, you need to pull this out of your formulary and increase the tiering on these medications. However, the ADA just said these drugs show benefit in these patient populations and may ultimately save you dollars on your Part A, Part B side. And so trying to balance that and depending on who you're working with, expand that lens and have members of those different departments, whether they're looking at your Part D, Part B benefits, Part A utilization, and then for your teams that are trying to improve inpatient utilization, making sure they're at the table too, and how you can minimize waste. I think for a life science company looking at that and trying to figure out how do we show the downturn savings, whether it is decreased ED utilization, is it decreased inpatient stay, how are we defining the waste, and then how long does it take to recoup it? And then how can you prove that to a CFO?
From an upfront perspective, there was some conversation earlier about baselines and rebasing. And I guess I'm just wondering, how is that taken into account? Are those, when you're rebased, David or Kathy, by a payer or by the government, how much of that risk that you take on in terms of your population, which tends to be a high acuity population, is that factored into that base, that new base?
It is, Neil. So whenever you start from your baseline of spending, it incorporates all of the risks that you have naturally. That's why, especially places that have tertiary centers like ours, feel good about it. So in trend-based things, the risk adjustment is pretty good. Risk adjustment on its face, I think experts say, it may account for 50% of variance, but so it's by no means perfect. One of the imperfect things is it relies on coding, and we've seen in Medicare Advantage that when the Affordable Care Act took out the extra 10 or 12% of revenue in Medicare Advantage, coding entirely made up for it. Just more aggressive coding by providers. That's a real problem. It's administrative. It's not healthcare.
Right. And for us, as you mentioned, I agree with you on trend. That's what we use in all our commercial populations. It's the trend of our current population. You know, last year's total spend. And again, we negotiated out of the COVID year, right? Fiscal 20 or calendar 20. And used kind of a combination of 19 and 21 to predict 20 for our 22 budget, which will be planned. And with our government payers, our risk is based on we negotiate a percent of premium spend. And so then the risk capture is important, obviously, because, you know, for example, for us, New York State, you know, premium is allocated based on lives, and they do risk adjust those lives based on, again, coding and documentation. So in fact, we look at historical percent spend of premium for our Medicare Advantage and Medicaid option plans, and then negotiate what we think is a fair rate of percent of premium for the following year. You know, somewhere in the, you know, obviously the plans want us to spend less, and we want to, you know, we want to get it up over 95. They want to get it below 95% of premium spent.
Armika, could we hear from you? I just wondered, how do you look at the market and at your strategy differently as a result of how most of your money comes in?
We'll get Armika's comments, and then we have to shift because Tim has a limited amount. Tim has a limited amount of time to get us started on the next topic.
Sure, I'll try to make it quick, Warren. I think it's a lot of what Kathy and Matthew have already said, right? It's, you know, this idea, Kathy mentioned this earlier, this idea of a controlled network, right? So this consensus building idea, I think that's, in my experience, the strength with Kaiser and other organizations who are physician-led. There is this consensus on care coordination, service delivery, inappropriate utilization, right? And that feeds into formulary costs, cost of inefficiencies, cost of inappropriate utilization, right? Like that is really where I think the success lies, right? Having, you know, as close to a closed network with consensus among care providers, that is the strength of value-based reimbursement models, in my opinion. And that's, you know, really where the strength lives in the Kaiser model, which is what Kathy articulated well, in my opinion, as well. I think something else that Matthew brought up is this idea of inefficiency, right? And I think that consensus building or consensus driven approach to value-based models is where you can also get this, you know, this rallying or championship from the physician level, from these IT folks, right? So I think it's, you know, a constant challenge amongst all healthcare organizations to get everyone, all of our physicians on the same page. But when you do, that drives everything else. And when we see quality go up, we have incentives in other ways, different from our normal fee-for-service models, right? Which is, I think, what we're all looking for. And then we get into this space where we have things like predictive models, predictive analysis models that help us to continue these practices of determining in the market how we'll plan for the following year, because we have consistent documentation, consistent care coordination, consensus on services provided, consensus on waste and inappropriate healthcare services provided. And then there's, you know, this support that comes from this administrative support that, you know, Matthew talked a lot about as well, that supports that, which gives us aggressive and consistent documentation and coding, which, you know, again, provides a different level of incentive. So I think, you know, I don't want to harp on it, but I think that the model is, the strength in any model is consensus amongst the service providers in a way that almost could be punitive, which is what I heard Kathy say.
This is obviously a great topic. We need to figure out how to spend more time on this, but this also brings up a good point that I'll ask you to, Tim Atterbury, to kick off this next topic that you brought up. And that is, how does the physician play into this? How do we align physician incentives with the physicians, and thinking about physician compensation, incentive alignment? As we're talking about closed and open systems, not everybody has the luxury that Armika does of having everyone within a closed system, and compensation is becoming a problem, especially when you got private practice groups. Tim, if you kick it off, Neil and I will, when you have to jump off, we'll carry the conversation forward.
Well, thank you. And sorry to kind of stop the good flow of discussion on that last topic. I thought that was very helpful, and I agree, Warren, we need more time, but I think they're linked. And so let me just kind of tee this up, and I'll probably have to jump out around 2 or 3 minutes after 3 to jump on my other call, and I apologize to everybody. But a couple of things that kind of strike me on this topic, and all of you are probably familiar with employed physician model arrangements and compensation arrangements, and I've been involved with this for most of my career. But it seems that we really have gravitated because of legal issues, fair market value, commercial reasonableness. The attorneys have got us into a mode where we think compensation, we immediately think per work RVU. And having talked to lots of physicians around the country and been involved with trying to redesign comp plans, you know, one of the things that's clear is physicians look at the per worker RVU model as, in many cases, a moral injury, that we're reducing physicians to worker bees, commoditizing them, but the only thing they can possibly do is go out and see patients and code and generate a work RVU. We're not. So I think part of our problem is our compensation plans, not only are they not aligned to the reimbursement that the organization may be moving into, this risk-based, value-based, but also they are telling physicians, just punch the clock, produce a work RVU, we'll pay a per work RVU conversion factor and go home. And so I want to get the group talking about ways that we can optimize and maximize what I call the physician contribution, physician effort. And the physician is worth more than a work RVU. If they're not, then that's really shameful for us that we have reduced the physician down to that. So think about how can we recognize physicians and incentivize physicians for efforts that relate to efficiency, throughput, cost savings, input pricing, better turnaround, faster turnaround, to getting patients in the door, accommodating more patients, both from a panel size and access size, strategic execution, quality and safety, and patient experience. So how can we move the compensation from one model, pure work RVU, to a hybrid model that integrates elements of non-clinical services performance and turns the physician into, just instead of being a worker producer, turns them into a thinker, leader, worker producer. So we get both. And just a final comment, in the last couple of months, the CMS has given us some guidance in November on how to compensate physicians. That came out, I'm sure some of you have read that. It's November 20th, 2020, that really starts to explore how can we relax some of the compensation rules to enable health systems to compensate physicians for non-work RVU contributions, and relaxing those civil monetary penalties rules, which that has been, at least for my career, every time I talk to an attorney about an innovative idea for compensating physicians, the first thing they put up, besides Stark and anti-kickback, is CMP. We can't do that because of CMP. Well, this November 20th guidance relaxes some of that. So I want to hear some experiences you've had, maybe lessons you've learned, the barriers you've encountered, legal and otherwise. But I'm really interested in your idea of how do we optimize the design of physician compensation in order to maximize the physician contribution to the organization.
Tim, this is Steve Franklin. I'll just comment real briefly. When I was there, when I left the organization, though, the biggest problem we have, just as you talked about, is misaligned incentives. When you talk about RVU, they lived and breathed by the RVU, but as an example, you had a bell curve of RVU. The more RVUs produced, actually, the less you made at the other end of it to try to drive people towards the center, which was really a popular notion for the high producers that you can imagine. But we tried to move towards the medical group to drive just as the things that you're talking about: care management scores, patient satisfaction, the panel sizes that you talked about, all the things that, again, even in leadership meetings, we tried to drive them as far as incentives to what I call the good character type things that you would expect. And it was driven actually by our physicians. We had a management council that made the determination as people that didn't hit these scores of what potentially would be a positive or a punitive aspect of related to their compensation. So I struggled, I'm sure like everybody did, to try to find the right incentives to get people to be productive and not squelch the people that were high producers, yet trying to get work for everybody so you don't have the people that covet it all the time.
Hey, Tim, this is Mike Blair, Centric Care too. This is a really timely discussion for us because we're in the process of assessing our current compensation models and how we may want to restructure those going forward. And part of it is probably recognizing that what we're trying to drive through primary care is going to be different than what we're trying to drive through specialty care. So it may be a situation where with primary care, it may be more panel related. So if you take on a larger panel, that may affect your compensation level. And we've been exploring on the specialty care level, how do you implement a comp model that's more balanced? So we want to bring in all the elements of the quadruple aim. And one of the, this is early on, so we haven't really come up with anything definitive, but we've thought about the idea is there's still some component of it that's the work RVU, but the conversion factor flexes based on how well you perform. So if you max out your outcomes in your patient experience, in your citizen stewardship, it would actually bring your conversion factor up. So you're compensated, for those items. But bringing some balance to it. So if you just don't have the productivity overall, it would bring that compensation down. Now that sounds really easy when the finance guy is kind of laying out what that math would look like. But when you actually try to operationalize it, I think that's where you run into some of the challenges with it. But I absolutely agree with what you're saying there. It's trying to bring all those elements in there. And so it's more balanced. And then, for the most part, what I find is, a lot of our physicians really are driven by, their outcomes and the experience of so they want to be compensated, in a way that recognizes what they're trying to do anyways.
Yep. Tim, this is Tim Maurice at UC Davis. We're a closed model academic health system, but we are working very, very hard on redesigning our compensation models as well as what we call our funds flow models. And our primary goal is to separate funds flow from compensation.
Yep.
Funds flow is a payment from the health system to the medical group to meet the clinical objectives. But the compensation plan is really administered department by department, administered by the chair of that department, working with the faculty to develop alignment along clinical quality goals, character goals, as well as balancing time between clinical work and academic work, teaching and research. So as much as we have faculty trying to drive us to drive the funds flow to match compensation, we work very hard to keep them separate so that they can use peer review and peer pressure to develop those quality incentives and reward faculty that benefit the group as a whole. And that's where I think physician groups work much more directly when they're in affinity models, when they're in single specialty models. And we separate our primary care group from our specialty groups in that the primary care group are treated as a holistic group and are paid more by panel and rewarded more by panel and patient satisfaction. Whereas the specialty groups are organized by clinical specialty, organized by a chair.
And Warren, I'm going to apologize. I'm going to drop off. So keep the conversation going. I look forward to hearing some feedback.
Thank you, Tim. This will be recorded and we'll let you look back in. Thank you for starting.
My apologies, everybody. See ya.
Yeah.
I have a quick question. This is outside of the area of my expertise, but I'm wondering with the emergence of telehealth, are there any considerations in physician compensation with so much of our healthcare now moving to a telehealth model? I could be completely off base there, but I wondered if telehealth had any play in determining any physician compensation models or anything like that. I know reimbursement has been a challenge, and there are lots of codes that you probably are unfamiliar with using to get reimbursed on that, but wondering if telehealth had any sort of, it was a driver in physician compensation models at all.
Well, again, this is Tim Maurice. We ramped up telehealth pretty rapidly with COVID to 50% of our total activity, and we do about 1 million visits a year. And it's now dropped down to about 25% overall, with still about 40% primary care and a smaller percentage in certain specialties. But we treat telehealth no different than in-person visits in terms of measuring physician activity. And there are RVUs associated with it. So we use the RVU model for funds flow to measure telehealth. And as a result, it's maintaining a pretty stable consistency at the 25% level.
Yeah, Tim, that's what we do too. And obviously I work and live in an academic model, and that's what we do too. The one thing we've done, same thing you're describing, the importance of separating funds flow from physician productivity, physician activity. We, about 5 years ago, brought in a new leader of our practice plan, a physician who was charged with developing across all of our departments, specialty, primary care, everything, a coherent comp plan. And it was developed based on, double AMC or benchmark salary rates by specialty, by professorial level, because all of our employed docs are faculty. And then the comp team that he led, they determined what is the productivity around, what should the productivity be in our organization around that professorial level, around that salary that would have been benchmark. And, faculty could negotiate to be at 90% clinical if they are 80% clinical, if they took on, 10 or 20% responsibility for something else, either in leadership, funding on a research grant obviously counted. But there were new categories of citizenship and activity that physicians would take on. So they would have to produce RVUs at 80%, even though they were full-time, their RVU requirement range was 80% if they had 20% other activity that they were doing that was valuable to the organization. So, was part of their salary. And then for the people that really wanted the opportunity to make more, there were thresholds upon which if they exceeded, they would be eligible for extra compensation. If they exceeded, this RVU range, but it wasn't a fast pay for RVU. It was a range that they had to meet for the level they were at and the percent clinical they were. They could go over that and earn more, but they had to reach that range, and they had to work with their chair on negotiating other responsibility that had value to the organization to work down their clinical FTE. And it's really helped, I think, align incentives in a different way. That's been helpful for us.
So that's great, Kathy. And Tim, it sounds like you're sort of on a similar pathway. What this all involves, it sounds to me though, is taking a certain pool of dollars and allocate in a way to optimize the outcomes that you get from the groups or the faculty, ultimately for the enterprise. But in reality, from what I've seen, what I've heard, and this would be true also, for example, like Centra Health, who has an employed base, there isn't enough money generated by the physicians directly. There's still what I would call an investment, a subsidy, whatever you want to call it, that has to go back from the hospital side to the group side. And is that something that is that the perennial problem that we're going to always have to deal with? And how much of a subsidy or investment are you willing to accept? And I guess this is a question for all on the call right now. And it gets to one of the questions. It's not something that an academic medical center can separate itself from because it needs the faculty, but a community-based health system, it sometimes looks at the trade-offs between having some sort of clinically integrated network where there's some sort of contractual relationship versus employing those physicians. And Kathy, you've even talked about that some of your physicians are contractually involved as opposed to being employed. So how do you get a balance there? And is that balance necessary? And is this problem ever going to be solved in terms of that investment from the health system to the medical group?
Yeah, I'll speak to that quickly. For us, we've been in value-based care for over 20 years. So we accept physician capitation for both specialty and primary care. We don't no longer accept hospital capitation because it's not properly risk adjusted for an academic center. But we have been in capitation, and we compete with Kaiser on a daily basis for many, many years. So we're very disciplined in our developing clinical protocols, developing clinical standards, using our EMR to communicate effectively and care coordinate. And that's essential. So, but that subsidy still exists. And what we've done with that subsidy is basically say to the physicians, you are now payer agnostic. We will keep all of your professional revenues, and we will pay you per work RVU independent of the payer, agnostic to the payer. That's putting a substantial risk onto the health system, but it's the only way to align around value-based reimbursement in the future.
Yeah, I would agree. Oh, go ahead, Kathy.
What? No, go ahead, Mike.
Oh, yeah, I would say, having in the academic world, as Tim knows, and having, moved here into the, into a community-based practice, we're really similar to what Tim said. They were really focused around determining what it takes to have a really well-functioning group practice plan, in recognizing that we have to probably separate the revenue generation, from what the compensation looks like. And trust me, it pains me as a finance person to say that. But we find if we can get the physician group to really rally around those strategies that we believe, will pay off it long term for the health system, which really driving around, how do we have a really highly functioning group practice plan that the long term benefits are better than tying specifically, to the actual revenue generation. And probably a good example of that, there was mention earlier of the changes that CMS came out with. Well, you can imagine how, seeing the changes they made in work, RVU weighting, and probably, rightly so, weighting it much heavier to primary care, as opposed to, some of the, the procedural areas. It was really key for us that we could have that conversation around how collectively do we advance the group practice plan versus any specific specialty within it. And it was valuable to us to not have to keep tying it back to what the reimbursement model looked like, but come back to what our principles were that we agreed on, what would make a highly functional, group practice plan in the future.
Maybe this is just an academic point, but in the Kaiser model, hospitals are a cost center. And people come to Kaiser because of the value of the whole enterprise, which I would say is probably driven mostly by their experience with physicians. To me, it just shows the gap between a fully value-based arrangement and what we have in fee-for-service.
I do have a question for the group who do not have closed, who have open faculty panels. How are you keeping doctors aligned with your organization, or what is your strategy to keep physicians from leaving your closed model and going to these single specialty groups where they can earn more money, but it becomes now competitive to try and keep a faculty engaged? And I know we're gonna run out of time, but any thoughts on that? What your strategies are to keep your physicians?
Going through COVID certainly did help. Back last spring when there was no revenue coming in, we didn't hear as much complaining from the faculty, and heard a lot of appreciation for being part of a larger health system in which we're in the financial position where we could continue to pay salaries even though there wasn't work RVU productivity.
I think too that the complexity of managing sophisticated IT systems has driven, most of we hardly have a primary care individual physician that's in private practice anymore. They've lined up either with our system or the other big system in town. Same thing with cardiology and cancer. Some communities still have a lot of private cardiologists, community-based. They've all lined up with one system or the other. Because of just the complexity of managing office practice, managing the quality metrics, managing all the IT infrastructure that you need to have to be successful. So our challenge isn't so much losing them to a private group, but it's between systems, right? They leave to move to another larger system, or where they get something that they believe is important to them that they couldn't get here. But the marketplace has very much changed in our region with regard to employment versus private practice. And there's not a lot of private practice left.
Something I'll come back to it in a future discussion is the issue with surprise billing. So you do have super specialties, single specialties like anesthesia, emergency. Sometimes your hospitalists and others that are lining up as single specialties, and then they're not joining the contracts with your hospital system. So the incentives become unaligned in taking care of patients. The government may step in on that one, but again, you're competing with these large single specialties for all the revenue. Another thing to talk about in the future would be how, the largest employer of physicians right now is Optum, and that in the future will be an issue if physicians start becoming employed by the payers, and then what do we do? How do we hang on to our physician base? So anyway, I don't know that we have time for that. But
yeah, that is a worry.
John, did you have a comment?
My system is much smaller than some of the others here, but we have what for us is a large neurosurgery group. And, we're wrestling with different ways to, within the community, it's probably 70% of the neurosurgeons in town. And so we're questioning having our group do call and do other things at other hospitals. And we've been looking at some sort of profit sharing models. I saw a presentation on that where you could have some type of a profit sharing infrastructure. It's just that the physicians need to be paid equally so that you can avoid any stark issues. We haven't done that yet, but it's something we're exploring.
A final comment. I think it was someone said earlier about the Kaiser model and the patient experience is driven primarily by physicians. I think that is an important note for our previous conversation as well, as it has a substantial impact on kind of that value-based discussion and cost. So I think that's an important note to add to our previous discussion.
Excellent points. Thank you to everyone for your contributions. We've got 15 minutes remaining in our time together, and Mike Blair is going to facilitate the final discussion, which now gets into how we engage with patients. How do we keep patients engaged and get them to re-engage? There's been a lot out there of patients delaying care because of the pandemic or for other reasons, and now how do we re-engage? Mike, do you want to lead us on that?
Yeah, thanks, Warren. I'll start by maybe giving a little background as to what's happened here in Minnesota, and I'd really love to get some thoughts to the group. But if we go back to last spring around the first COVID surge, all the hospitals in Minnesota agreed that we would put a temporary hold on anything that was non-critical. So we dialed back services pretty significantly from mid March through mid May, and then we branded what we called the road to recovery, and that was really around how do we get the health system back open. So following that first COVID surge, really a lot of efforts of getting the system fully open, trying to get back to a more normal. Saw the patient utilization start to recover. And then as we entered into the second COVID surge, which we saw kind of late October into November, the first part of December, and then coming out of it, what we actually saw is the patient utilization actually started to go back down the other direction. So for us, our admissions have been down about 15% year over year. Surgeries, inpatients been down 11%, outpatients been down 22%. Pretty consistent on our clinic visits have been down about 10%. And it feels like we're stuck. Like we got the system fully open. We got the utilization to start coming up, but we've seemed like we've gotten to the spot where it's just leveled off. And originally where we saw, really much higher patient acuity. So we had, high case mix index. That higher acuity was offsetting a lot of the impact of that lower utilization. But now it appears like the utilization may be dipping again. And we're starting to see the case mix index come down as well, which is like the worst case scenario to have them both going down at the same time. So I would be just curious what the other systems have done. We're talking about probably a strategy that's part broad, where it's just getting out advertising into the community about getting back in. The health system's open, it's safe to be in the health system, and then be more targeted, because for the most part, we've been doing all of the vaccinations here in central western Minnesota, so we know who's been vaccinated. We also know who hasn't been into the health system. We also know who has chronic conditions, and part of it is looking at a more targeted approach of like, how do we reach out to these specific patients and say, you need to come back in, especially if you have chronic conditions. If you haven't been in for a eye appointment or for a physical in 4 or 5 years, maybe reaching out to those individuals as well. But I'd open it up to the group to see if you're having similar experiences. And then if you found something that's been successful, we would love to hear it.
Mike, when did you in Minnesota have your strongest surge in terms of hospitalized COVID patients?
So our strongest was the second surge, which started in October and ran through about mid-December.
Just a comment. We had a second surge that was the highest in that same time frame, and our volume's been extremely robust. We're hitting OR records and inpatient admission records that are really high. Our payer mix isn't always that great, but and again, we're a safety net, but we've been very full.
Wow. Hey, and John, have your Medicare insured patients, have they come back post second surge?
I haven't seen the data in the last month, which is where we've really gotten the high volume. I just know right now our nursing team's fighting to be staffed, and our OR is opening on weekends to extents we've never seen. But I haven't seen the exact age base in that. I'm happy to share that when I get to see it.
Sure. Yeah. Interesting.
Yeah, Mike, at Mass General Brigham, we launched a major advertising campaign in the fall, and part of it was essentially developing the capability to treat patients safely and to assure them that you could, whether there was a COVID surge or not. And so we had a big surge in after Thanksgiving and all of that. And but we did not see the kind of real volume hits that we had quite a resurgence in our volume in the fall, and that's maintained.
Yeah, we did as well in Rochester, and likewise had the big surge was October, actually through mid-January. But one of the things that was helpful for us, and I don't know, is we really had a great relationship with our local health departments, working together around messaging to the community and that kind of thing. And so we really started this campaign of, as the COVID second surge went down, we had a real campaign about health and safety and non-COVID illness, and not to get caught up in non-COVID situations where heart disease, cancer was going undiagnosed, heart disease was going unmanaged, stroke was on the increase. Really trying not only assure people that it was safe to come to the hospital because of the redesign, but also urging people not to ignore their health status, especially if they had underlying conditions, because failure to treat and manage non-COVID illness could be as high risk for people as getting COVID, if not more so. And it was more of a community service announcements. Certainly our system participated in that, but I think it helped the general, across the region, help people, I think, begin to think about, okay, I'm not going to let these conditions or these concerns or these surveillance screenings go unmanaged. So my question for you would be, is this a region-wide downturn or is it fairly localized to your system? And is there anything you could do on even a regional basis to assure the public that it's time to come back and seek healthcare as needed?
In the Milwaukee area, it's the same. Where actually 2 out of the 4 systems have seen spikes of increase and 2 haven't. But it's similar things with the PSAs. It seems like the combination of the systems that have done better have used a PSA feeling, and they've also concentrated on that specialty care, and we're clean and we're open for business, and these are the things we're doing post-COVID. So it's been pretty consistent with the ones that have been up, have been heavily involved in marketing campaigns with the public.
Yeah, here at UC Davis, we've been actively involved in public relations and have been seen as the trusted experts in addressing COVID, both in the initial phases and in the recovery. We have a children's hospital and an adult hospital, and we're a trauma center for both. So that definitely expands our exposure. And we've had experts in both children's services and adult services, in the media routinely, both regionally and nationally even. And so that has really built patient trust. And as a result, there's only a few areas where we've seen a decline in patient volume. Beyond that, we've fully restored patient trust and engagement. We also have been on Epic for over 15 years and have really built out Epic to engage with our patients proactively, to keep them informed through MyChart, use MyChart for telehealth and not make it a separate experience. And in doing so, create a strong connection with the primary physician and the patient.
Yeah, that's really, really helpful, Tim, especially the MyChart concept too. Just out of curiosity, Kathy, I don't, I realize you're in Rochester, but I don't know if you've got other hospitals that are out in more of the rural areas around Rochester. Have you seen, because that's what I wonder as well, is there something to that being a more rural area, or maybe there isn't, but I'm wondering if you saw something in your rural areas.
That's what I was wondering too, Mike. I'm glad you pointed.
You raise a good point. Yes, we do have rural. Most of our affiliates, except for the 2 right in Maine, Rochester, are out in rural areas, and their volume has softened. Even though they've participated in a lot of the same things we've done. I think a couple of things though, a lot of their admissions every winter related to flu, and we are seeing no flu. I don't know, in New York State, the flu incidence this year is way down. And even some of the other kind of ailments, injuries, people aren't out and about as much. So some of it may be related to certain diseases we see a lot of it. We typically see a lot of in the winter, just not seeing as much of, as well as, people deferring care. We're really trying to go after the deferral of care and really try to help people not do that, through trusted messages. But I think there is a difference in the kind of illness we're seeing because people have been so careful about being real active. And certainly the masking and all the prevention have avoided a lot of the typical infectious diseases you see in the winter.
Yeah, that's a really good point, Kathy. We've seen that too, with really virtually no infectious disease this winter. Yeah. Although one of our orthodocs said just give it a little time when they all go back to the gym, when they haven't been working out for the last.
Yeah, there you go.
Armika, what has Kaiser's strategy been in all of this? Because you have a different model.
Honestly, I think the significant difference is, well, I'll say this, we are experienced the same. Our experience is the same with the flu rates. It's interesting, our ID docs that lead this work regionally make a joke with our kind of weekly messaging around COVID rates. It's like all things COVID, and by the way, there's no damn flu. So that's the conclusion of it.
Yeah.
Right? Like as if anyone is even thinking about that. But I think the difference in what I've heard from my colleagues here is that, we've approached this in a more comprehensive vulnerable population strategy. So when you think about targeted and trusted messaging and access tools like, online access to MyChart and those types of things, thinking about it from the perspective of, how COVID has exacerbated people's perception of care or risk, probably is a better word, the perception of risk related to COVID and even accessing standard care. And so we have thought about it from that lens, right? So how do you create almost a Burger King approach to targeted messaging, thinking about the different populations, age, gender, identified sexual orientation, culture, race, ethnicity. So thinking about it from that lens and not, and how COVID has changed people's decision-making and motivation to access care. And then framing our messaging approach and even targeted outreach from to our members who we want to bring back in for kind of, standard screening and primary care. That's been the most substantial difference. And I think it's been really, really effective. We have leveraged this consumer voice in a different way. So really thinking about, how all of these nuances and people's decision-making to access care and how they think about it, maybe as a minority, and what COVID means to them and what vaccination means to them. And then what all of that, drives their decision to come in for a pap smear. And so that has been the lens by which we've approached it. It has become very involved, but it has been very effective.
Hey, Mike, I just was wondering if there might be a financial component to this. For example, people in your population who've lost jobs and therefore have lost insurance, number one. And secondly, people who have chronic illnesses and by say early February, they've already met their deductible. By May, they've met their out-of-pocket maximum, and they don't want to dive into that financial issue at this point in time because they've been accustomed not to going for that kind of care. I wonder if there's that component.
Yeah, and Neil, maybe I'd add on, Armika mentioned the patient portal. So I think it's a huge way to sort of in a personal way connect with your patients. And I wonder if those portals exist in some of your rural communities, Mike.
Yeah. I think what Armika said there too, and they kind of resonate with what Kathy said too. The one angle now that you think about we haven't pursued is really working with our payers. And they really need to get for the cancer screenings in those, which can lead to really bad things downstream, really costly things, is really getting them engaged as well. Like it's in all of our best interest, and also in the interest of just population health. We need to get their members re-engaged, get them back in for screenings, or like we all know, it can lead to some pretty catastrophic things, over time.
Okay, we are up at the end of our 90 minutes, but if people can stay on for an extra minute or two, I would like to be able to hear from Matt Malachowski about medication adherence in this and activation around medication adherence and what you've seen there.
Sure thing. At Ochsner, we found the clinics bounced back the fastest. Our probably most aggressive surge by the numbers was that October through December. But I think emotionally, the biggest impact it had on our ability to provide care was March. Our pharmacy services continued through all of the surges. We transitioned to a curbside pickup model and converted all of our patients to mail order. And so we found that our medication adherence locally, it did well. And our chronic medication utilization specifically did not diminish. From a PMPM standpoint, the specialty, obviously, where you had new patients not entering the clinic for a couple of months, that specialty spend took a bit of a dip. But the chronic disease management, especially for established patients, we found did well and continued. We also support that through a refill center. So where you had patients deferring their yearly visit, and where we had patients that were participating in telehealth, we have a system to review those patients. And if it's a medication where they've had their labs, they just can't come in to see the physician because they're scared, we will work with the physician to get them like an extra 90 days supply. and then reschedule their appointment, thus diminishing that interruption between when those prescriptions expire. We give them the benefit of the doubt and are allowed to continue therapy. And the FDA and the Louisiana Board of Pharmacy supported a lot of these moves. And the good news is it looks like they're going to continue to support those moves. The other big one would be in infusion centers. So Ochsner, luckily, for better or for worse, we opened a new infusion center in April, which isn't necessarily from a cutting a ribbon standpoint. You're not going to get the opening ceremony that you'd had hoped. However, it provided a venue where we could provide testing, have social distancing, and continue to provide some innovation from an infusion and clinic administered medication therapy. So instead of, if a patient was adverse to going into the hospital where their clinic is normally seen for some of their medication that were provider administered, we could fast pass them through our new infusion center. And we could create some revolving door scenarios where they don't run into other patients, they don't have a waiting room, and started our innovation to drive through vaccination. And I think Mike dropped off. Oh no, Mike, you're still here. So the other question I would have for you guys with return to care is, how is your vaccination efforts being received? And have you gotten any patient satisfaction bumps from that? So we found when we started our vaccination series, we actually got really good buy-in from the community. And we actually saw our Press Ganey surveys and several of our other top box metrics go up with in the facilities that we were doing vaccination services, which isn't necessarily a revenue driver, but we saw a big patient satisfaction pickup. So I think that would summarize our experience with medication adherence. But we put in a lot of safety nets in place to make sure that they wouldn't fall off. And then I would probably say where we saw the biggest divot was in specialty areas, new starts.
Outstanding. Thank you,
Yeah,
Matt.
great.
Well, folks, we are over our 90 minutes. This has been a marvelous discussion, 3 discussions. Obviously, we're trying to squeeze too much into too little time. I think we may have to only do 2 topics next time, but super information. I think what we'll do is we'll summarize this. We'll follow up using the Survey Monkey tools to really ask for some additional feedback. What I'd love to try and find is, several of you mentioned several best practice activities. You might not even think of them as a best practice, but they may be things that could be modeled or implemented in other places. We'll follow up on those. We'll go back through and we'll share the notes. Thank you, Andrea, for your hard work on those notes. That was a lot harder than I thought it would be, but you did a great job with that. We'll follow up with the notes with everyone. We'll also follow up with some questions about some of the best practice models that you have. And then if there are opportunities for us to try and share those ideas around in a way that helps those on this call, but also others to implement these best practices. Any final comments from Neil or Sarah or anyone?
Thank you all.
Yeah, great discussion.
Thank you so much for your time and your energy.
Thanks, guys.
Thanks, everybody.